me to the wonderful place here in the Engadin again this year. And I would say, as the cavalry has been out, now it's time for the native. And those who know a little bit about politics, they know what I mean. So, when I got this task, I was a little bit unhappy. And fortunately, I found some literature which made me then more happy. And we had some own results which I can present to you today. So, first of all, pathology is very important, as we have seen, and this is just like something to give you an introduction. This is the oldest case of a prostate cancer which was found in a mummy 2,700 years old. So you see, pathologists, they are really useful. They can help us in many situations. And even in these very old times, prostate cancer was present not only in kings, but maybe also in other men. So, positive surgical margin is an independent risk factor for local disease recurrence, need for salvage treatment, biochemical recurrence, and development of distant metastases. But positive surgical margins, as we have heard already, are also used as a surrogate parameter to evaluate the quality of the surgical technique. Now, my task was to have a discussion with Christian Barret regarding robotics and open surgery. Is there any difference? And so I will have the discussion with you. But let me just give you some information. So what has been published so far is rather poor. And as you see, these are not very old publications coming from 2009 and 2010. Coelho has used the data of Patel, and they stated that the clinical stage of the tumor is the most relevant predictor of positive surgical margins in robotic radical prostatectomy, which is not very attractive as information. And 2 years later, we got this publication where Patel put together about 8,000 patients, and these were the results regarding the positive surgical margin rates, and this was the former statement, and the new statement changed a little bit, but is still not very attractive, because now he's saying that pathological stage and preoperative PSA are the most important independent factors for the positive surgical margin rate. So still in 2012, there are no new information giving us a possibility to predict positive surgical margin rates before surgery. Fortunately, I found this publication, this very recent publication. I don't know whether Guido Sauter knows about that publication. It's coming from Johns Hopkins. And they were looking to a series of patients of the year 2007. And all the specimens were re-evaluated, and they had all three kinds of surgery. So it means open surgery, conventional laparoscopical surgery, and robotic surgery. And they just identified about 96 patients. And these patients were subdivided, and all the specimens were cut again and then re-evaluated. And as you can see, if you look to all patients according to the radical prostatectomy modality, there is no significant difference in terms of positive margins, whether it was the robotic laparoscopic procedure, the classical procedure, or the open surgery. The only difference which could be found was if you look to those cases having only a single focus, then you see a difference between the groups. And you may see that there is a difference regarding mainly the anterior positive surgical margins in the robotic group with regard to the others. But this is just for single focus cases. They were also looking to the question about the single focus and the multiple focus cases, and you see the distribution between the different groups. There is no statistical difference between the groups. They were looking to the length of the positive surgical margin, which is also one of the main possible new predictive factors. I will show you then just some results of our own data. And they subdivided the groups between 3 millimeters and more than 3 millimeters. We did the same, but we were looking at 1 millimeter only. I will just give you then the information in a few minutes. And they were also looking to the mean linear length. It means that is the sum of all the length of positive margins, whether you had a unifocal or a multifocal case. And you see that there still is no difference between the three groups. I will just switch over this. And in summary, they could find that there is no difference regarding the positive surgical margins between these three modalities of surgery, and that also the biochemical recurrence-free rate is not different in this rather small group of 100 patients, but which was looked very, very carefully, and it is a tremendous work to do that job. So let me just give you some information about our own study, which soon should be published. We had a group of pathological specimens from Regensburg and Zürich, looking through all three kind of surgery types also. And our pathologist was looking to the total linear PSM length and the focality. And these are the results. So all the specimens were reviewed, and the tissue microarray was then produced. There were 6 initially. 223 patients had a positive surgical margin status, and we had at the end 63 patients which could be followed because there was a median follow-up with clinical data of about 6 years. So these are just the characteristics of the patients. You may see that in this group there is quite a high number of patients with a PSA over 10, which is certainly reflected by the time of 1997 up to 2007, where the data were collected. So this is the way how the prostate normally is examined. This is how the prostate is cut by the pathologist, and we take just one probe, which is used for the biobanking for our PROCOG study. This is a whole slice which is cut into 4 pieces and goes then for biobanking. The specimens normally are inked so that an orientation is possible, as you have seen before. And these are some interesting slides. So pathologists are looking very keen to all the specimens, and you may see that actually we get some results like in this case where we have a 0.5 millimeter positive margin rate, but it is also possible that you get even such information that your patient has a margin rate which is of about 0.1 millimeter, as in this case. And you may see it here in the cytokeratin staining very well, whereas in the hematoxylin eosin, it was Professor Moch who supposed that it would be a positive margin at this level. So I think it depends very much on your pathologist and on his ability to identify these positive margins. And certainly these positive margins cannot be identified during frozen section analysis, or maybe Guido Sauter can give me some more information about that, but it takes time, and to get all these small positive surgical margins, it will be really difficult, even if you cut all the prostate. Okay, so the histopathological evaluation is done in this way, that we use the apex, the base, even the seminal vesicles in this case, is the anterior and posterior part on the right and on the left, so that we get 10 specimens. And these are the clinical results. It is obvious there is a difference regarding recurrence-free survival for those having a positive surgical margin and those having not. So this is the distribution of the PSM length. You see that we had only 12 patients with a surgical margin which was less than 1 millimeter. So we subdivided with 1 millimeter and looked at the results, not like the Johns Hopkins group. The other question was about the focality, and you see that about 12 cases were multifocal and the other one were only unifocal. And there is a clear difference also in the recurrence-free survival rate regarding margins. So it seems, with respect to our results, that the surgical margin, which is less than 1 millimeter, has more or less the same predictive value and the same outcome as those patients having negative surgical margins, whereas those having surgical margins longer than 1 millimeter, they are doing worse than the others. We did this, also an analysis with the 3 millimeter analysis, which gave the same results, but we have not plotted here the Kaplan-Meier curves. Focality was the second question, and also focality is a parameter which shows that unifocal tumors are doing better. Maybe the two curves come together because of the very low number at the end of the period where the patients were observed. And, but nevertheless, I think focality and the length of the positive surgical margin are important predictive factors. We did an univariate regression analysis which showed clearly that there is a 1.7-fold and a 1.9-fold higher risk if you have a multifocality or if you have a margin which is longer than 1 millimeter. We just did the same with a multivariate regression analysis, again showing us that there is a statistically significant difference with a 1.7-fold higher risk, and the same was true if we were looking to the multifocal and the unifocal situation. So, in conclusion, urologists should ultimately force their surgical pathologists to give good and relevant information, and subclassification of positive surgical margins, to my opinion, is mandatory for the quality assurance in radical prostatectomies, so that we can predict who will benefit from further therapies. Thank you very much for your attention.
Thank you very much. Any questions or comments from the floor? Okay. Yeah.
Thank you very much for this brilliant talk, and I can also support these data. We have seen in our group that the minor surgical margins that are below 1 millimeter, we always wait for the PSA value after 6 months when we decide for adjuvant therapy, and before that we don't do anything.
Guido, maybe can you tell us about, can you tell us about the possibilities of the different staining which you do maybe in Hamburg? Yeah. I don't know, what is your approach?
Would just like to come back on the ability to determine the resection margin on the frozen section. It's actually easier on the frozen section than on the final sample, because if you have an unclear result, you can make right away new sections. Otherwise, you have to order them from the lab, and it takes a day. And you see the tumor, and we can also do immunostainings in the frozen section exactly the stainings that you showed, but we hardly need it, because it's very rare that you have just one gland at the border and no other thing, nothing else. So.
But if you have the suspicion, like it was Holger who had it in this slide, would you then do the immunostaining?
Yeah, we often do immunostaining, especially in biopsies, sometimes also in the radical prostatectomies. That's extremely helpful, and it makes prostate pathology very easy, these immunohistochemical stains that there are, and that's definitely a very substantial help.
Okay. There was one question from Professor Jünemann.
Correct me if I'm wrong. I know two publications, one from Babayan and the other one from Epstein. And both claim that if it's 1 millimeter, the other said up to 3 millimeters, you just wait, because the recurrence rate over 10 years follow-up is 12% versus, I think, 19%. That's how we do it. If there is a new publication, I would like to know that, because then we have to change the concept. That means if we have a positive margin, less or around 3 millimeters, we wait.
Yes, no, there is no new publication. The information is still correct. We just did the analysis with the 1 millimeter, because with the new possibilities, the information will certainly come down, and if you have some more low-risk cancers, it might be the situation that you get positive margins like we had, 0.2, 0.1 millimeter. So this is really, I think, helpful for the future also. And I'm also very much interested to hear about lymph nodes and the impact on the outcome of the lymph node dissection. Yes, I know.
Dr. Jünemann, we have a little bit different approach. We don't take the length of positive margin to decide whether we do radiation or not. We include the PT stage and maybe even the Gleason score, the Gleason grade of the glands who attach a margin. So, for example, if you have a PT2 tumor and a positive margin, we know that the PSA recurrence rate goes from non-recurrence rate goes from 90% to about 70%. So we think, unless there is a suddenly Gleason 4 or 3 or 6 millimeter, we don't do anything in a PT2 tumor, no matter how the surgical margin is. Just in contrary, in PT3 tumors, the difference in positive and negative margin is tremendous. And I think it's shown in the Boller study about PT3 tumors and post-op radiation, that especially those who have positive margin in PT3 tumors have a big benefit from radiation. So we tend in PT3 tumors to do, so long story short, we include the PT stage in our decision whether we wait or we do radiation.
May I can respond just shortly?
So final comment.
I think this is the better approach, definitely. But what I've learned today, for example, is that I will do more nerve-sparing procedures in the PT3 cases. And since I'm doing histoscanning, I strongly rely on the histoscanning picture. And I'm always very happy if I do it. I didn't do it twice at the beginning. And it was always a big positive surgical margin. So if this is free, I will go home for tomorrow and start on Monday or on Tuesday doing more and more nerve-sparing procedures on the PT3. And then I think you are right. If you have a Gleason 8, of course, then you probably have to do a radiation therapy afterwards.